Welcome. In this explainer, we're getting right into a topic we see pretty much every day in the pharmacy: adult urinary incontinence. We're going to arm you with some really practical, evidence-based tools so you can counsel your patients with confidence and, really improve their quality of life. Okay, let's dive right in. Picture this. You're at the counter, it's busy, and a patient quietly, maybe a little embarrassedly, mentions they've been having some leaking. We've all been there, right? But that one word opens up a huge clinical opportunity. So, what do you do next? How do you quickly figure out what's going on and guide them to the right solution? That is exactly what we are going to break down. So to do this, we're going to follow a really clear, simple path. We'll kick things off with a super fast diagnostic tool to get our bearings in about 30 seconds. From there, we'll get into the nitty-gritty of managing the two most common types, that's stress and urgency incontinence. And then we'll wrap it all up by building a practical counseling toolkit that you can literally use with your very next patient. To really get the landscape here, the numbers make it pretty clear where we need to focus. Look at this. Stress incontinence is, by a long shot, the most common type in Canada. We're talking over half of all patients. Urgency and mixed incontinence make up most of the rest. So, yeah, this is why we're going to be laser-focused on telling the difference between stress and urgency UI and managing them, because that's what's walking through your door every single day. So, how do we kick off that conversation at the counter? We need something that's fast, but also really effective. And that brings us to our first amazing tool, a 30-second diagnosis using what's called the 3IQ questionnaire. The real beauty of the 3IQ is just how simple it is. Step 1, that's just your basic screener, right? Yes or no. Step 2 gets into the when, what are the circumstances? But step 3, that's where the clinical magic really happens. It asks the patient to tell you which one happens most often. And that single question is what helps you effectively separate stress from urgency, or tells you you might be dealing with a mixed picture. It's a whole diagnostic funnel in just 3 quick questions. So what's the result? Well, in about 30 seconds, you've gone from a vague complaint of leaking to a specific actionable diagnosis. This is huge. It lets you pivot immediately to the right treatment path and give targeted, effective counseling right then and there. All right, now that we have a diagnosis, let's tackle the most common type, stress UI. And the first and maybe most important counseling point is just clearing up the name for patients. This stress is all about physical pressure, not emotional stress. The mechanism here is totally key to understanding it. Basically, any increase in pressure inside the abdomen, think a cough, a sneeze, or even lifting groceries, that pressure just overcomes the strength of a weakened urethral sphincter. It's a mechanical problem, which, as you'll see, is why our first-line treatments are also, mechanical and behavioral. This is absolutely crucial. For stress UI, non-drug options are always first line. Your counseling here is everything. This means pelvic floor muscle exercises or Kegels. You've got to remind patients it can take 6 to 8 weeks to see results, so they need to stick with it. A referral to a pelvic floor physiotherapist, that can be a total game changer. For patients who are overweight, even a modest weight loss can make a huge difference. And of course, there are vaginal devices that offer mechanical support. These are the foundation of treatment, period. Now, when we do turn to medications, the options are pretty limited and very specific. For vaginal estrogens, your key counseling point is that this is for postmenopausal patients who also have vaginal atrophy. And super important, they don't need a progestogen with it. For duloxetine, you have to emphasize that this is an off-label use in Canada. You've got to counsel heavily on the side effects, especially nausea and potential blood pressure increases. And always suggest starting at a low dose, like 30 milligrams, to see how they tolerate it. Okay, let's switch gears. We're moving from the mechanical problem of stress UI to a completely different beast, urgency incontinence. This isn't about physical pressure at all. It's all rooted in the syndrome we call overactive bladder, or OAB. So unlike the mechanical issue in stress UI, urgency UI is all about the bladder muscle going into overdrive. The detrusor muscle just contracts when it's not supposed to, and that creates that sudden, overwhelming, gotta go now feeling. This physiological difference is why our whole treatment approach has to change. And just like with stress UI, non-drug options come first. But here is where your counseling is incredibly powerful. The source material is really clear on this. Bladder training, which is all about scheduled voiding and slowly increasing the time between bathroom trips, is actually considered more effective than medication. Think about that. That's a critical piece of info to empower your patients with. When it comes to drugs here, we have two main classes. With antimuscarinics, the phrase anticholinergic burden should be flashing in your mind. Yeah, dry mouth and constipation are common, but the risk of cognitive effects, especially in our older adults, is a huge concern. The mantra is always, start low, titrate slow. Then you've got mirabegron, which has a different profile. The main thing to watch for is blood pressure, so counseling them to monitor it is essential. And a great practical pearl, remind them the extended release tabs absolutely cannot be crushed or chewed. So the choice between these two really boils down to the patient sitting in front of you. If you have a frail, older adult, maybe with some baseline cognitive concerns, or who's already on a bunch of other anticholinergic meds, the risk from an antimuscarinic is just too high. In that case, mirabegron, even at the blood pressure monitoring, often becomes the much preferred, better tolerated agent. And that can make all the difference for adherence. And what about mixed incontinence? Well, this is where that 3IQ tool you used at the beginning comes right back into play. The principle is super simple and pretty elegant. You treat the symptom that the patient told you was the most frequent or the most bothersome. Tackle that main component first, and then you can reevaluate from there. So, we've covered a ton of ground. What do we actually do with all this information tomorrow at the counter? Let's boil it all down into our final section, a practical counseling toolkit with the absolute key takeaways for every single patient consultation. I want you to think of this as your pre-counseling checklist. Always start with the least invasive options first. And even before that, make sure you've ruled out other causes like a UTI or a medication that could be making things worse. Set realistic expectations. These meds help manage symptoms. They are not a cure. It's also critical to do a quick baseline cognition check in an older adult before ever starting an antimuscarinic. And finally, a really simple but high-impact tip. Advise patients to use proper UI containment products, not menstrual pads. It makes a huge difference for skin health and effective management. You know, this quote from the source material just wraps up our entire approach perfectly. It's the guiding principle that puts patient safety and their quality of life first, least invasive, reversible, and fewest side effects. If you remember nothing else from this, remember this. And that really brings us to our final thought. Our role as pharmacists goes so far beyond just dispensing a medication. By using simple tools like the 3IQ, by prioritizing non-drug therapies, and by giving targeted, empathetic counseling, we can make a truly profound difference. So the question I want to leave you with is this. Beyond just filling the prescription, how will you improve your patient's quality of life?